Well, thank you, Dr. Iwande. I'll be standing on existing protocol. I'll be taking the citation of Dr. Idowu-Deifa. He is a renowned orthopedic and spine surgeon. He completed his secondary school education at Federal Government Ologbolo in 1996 before proceeding to the prestigious University of Ibadan, where he earned his bachelor's in medicine and bachelor's in surgery in 2006. He had his residency training at the National Orthopaedic Hospital, bagging his fellowship Faculty of Orthopaedics in both colleges in 2007, also earning the Babatunde Onobowale Best Prize in Orthopedic Surgery, West African College of Surgeons. He is currently a spine surgeon at the National Orthopaedic Hospital in Lagos. Dr. Agbolabo is a member of FAOSpine, AO North America, International Society of Orthopedic Surgery and Traumatology, Nigerian Spine Society, and a young member of FMCOrtho. He's been to various workshops and has several certifications to his name. He's also a former president of the Association of Resident Doctors. Dr. Idowu-Deifa is happily married with kids. We welcome Dr. Idowu-Deifa.
Hello. Hello, can anybody hear me?
Hello, sir. I can hear you, sir.
Oh, okay. Hear me. Let me start by thanking the Association of Resident Doctors, National Orthopaedic Hospital, Igbobi, Lagos, for giving me this privilege and honor to give a presentation on the above topic. I must say, listening to previous speakers, it has been an enlightening scientific conference, and kudos to the president and her team with the response. Am I audible now?
Yes, sir.
Okay, I don't know. I think I'm having some internet issues. We'll start the presentation with, we will start the discussion of the principles of deformity correction in spine surgery. Please, can we go to the next slide? Okay, so by way of introduction, the spine, which is also referred to as the axial skeleton, is made up of spinal regions with distinct alignment and biomechanical properties that contribute to global spinal alignment. And it is important to note that there are wide variations in these regional curves from the cervical spine, the thoracic spine, the thoracolumbar region, the lumbar spine, as well as the sacral spine aspect of the spine. These different regions have different alignments and parameters and they all together, they contribute to the global spinal alignment. Now, the global spinal alignment has a much narrower range, such that you can allow more deviations within the different regions as compared to when they all come together to maintain horizontal gaze and balance the spine over the pelvis and femoral heads, as well as preserving postural balance. So the global spinal alignment is far more important than different regional curves. However, one must also pay attention to them. So spinal deformity basically can be defined as a deviation from this normal spinal alignment. Next slide, please. So in continuation, spinal deformities, they are manifestations of complex and dynamic processes that occur in all planes. That is, if we consider the human as a three-dimensional entity, you have the sagittal plane, you have the coronal plane, as well as the axial plane. But more evidently, we find spinal deformities more obvious in the sagittal and coronal planes. And as such, different divisions of spinal deformities for the purpose of education and also treatment. They've been divided into mainly the coronal plane deformations as well as sagittal plane deformations. When you have coronal plane deformities, it's largely referred to as scoliosis. When there's a scoliotic deformity, what usually happens is you label the scoliotic deformity based on the side where there's the convexity. So take, for instance, if a patient has a thoracic scoliosis and the curve is convex towards the right, is referred to as dextroscoliosis, while if it's convex towards the left, is level scoliosis. While on the other hand, you have the sagittal plane deformations, which are largely regarded as either kyphosis or hypolordotic deformities, as well as lordotic or hyperlordotic deformities. Clinically, it's important to also divide them into adolescent versus adult spinal deformities, because they largely have different clinical presentations, as well as some modifications in the treatment. Adolescents usually present like, or better still, we can call them pre-skeletal maturity deformities. These are deformities you find in children, usually less than 18 years old. Most of them are usually due to developmental abnormalities, congenital malformations as such. Occasionally also you may find some childhood tumors contributing to deformities. But the majority of them are usually adolescent idiopathic scoliosis, whereby the major focus of presentation is cosmetic concern. Whereas in adult spinal deformities, you have them presenting more with axial pain, neurological dysfunction, and difficulties in functional capabilities. So it's important for one to sort of compartmentalize these patients when you're dealing with them. And successful treatment is usually aimed at achieving satisfactory balance in both the sagittal and coronal planes, regionally, but more importantly, globally. Now, the goals of deformity surgery are largely to balance the spine and ensure solid fusion in that balanced spine. And this will in turn relieve pain and also prevent further deformity. And secondarily, when you achieve the curve correction, the patient's appearance becomes a lot better, which is more like a primary goal, especially in adolescents. Please, next slide. Next slide, please. Okay, so now it's important for us to talk about what is referred to as the cone of economy, which was postulated by a French spinal surgeon, Dubosset. And he discovered that there's this inverted cone of economy in which every human can have some form of allowance to undergo some deformations. And outside this cone, there is the need for some form of external support. And as you can see in the slide, you see that at the region of the legs, the feet, the cone is far smaller compared with that at the pelvis, and then when you move upwards. So if a human stands within this cone and one develops a deformity that sways forward or backwards or laterally, there's a limit to how much that human can develop such deformities without any external support. And even at that, if such deformities persist, they lead to a lot of muscle fatigue, progressive disc degeneration, facet arthropathy, which will worsen pain. This is more important, especially in adults. And if you can see on this other side, on the left-hand side of the slide, you see the depiction of the skeleton within the cone, and is a limited cone of economy. So this was postulated by Duboset in order to emphasize the importance of adequate global spinal alignment. Next slide, please. Okay, now etiologically, we can discuss the causes of spinal deformities, looking at the different planes, as the sagittal and the coronal planes. Mainly for sagittal plane deformities, you find a lot of different causes like spondyloarthropathies, of which ankylosing spondylitis is a major cause. Schwann's kyphosis is also very important, especially in children and adolescents. Then there's the issue of the flat back syndrome, which in some cases may be iatrogenic after some form of spinal surgeries, and then there's loss of the physiologic lumbar lordosis leading to flat back, and then there may be some compensation of the thoracic spine, which may increase in kyphosis, and that will distort the sagittal plane. Some patients may also suffer vertebral fractures, either osteoporotic or traumatic, and heal in such positions with some form of kyphotic deformities. More commonly that we see a lot of patients with advanced degeneration of the lumbar spine, and as such, there's usually reduction or loss of lumbar lordosis, and in some cases, it may even progress into kyphotic deformities of the lumbar spine. Neuromuscular congenital malformations. Infections are also important, especially in our environment, where patients that have pyogenic spondylodiscitis or tuberculous spondylitis of the spine with subsequent collapse of the vertebra, and then develop post-infective kyphotic deformities, which may also contribute to neurologic compression. Apart from, it's important to also note that it's not only in the spine per se that one can get these sagittal deformities. They can also occur compensatory to hip and knee flexion contractures. So it's important to always note that, to be able to differentiate where there's a structural sagittal deformity and that of a compensatory sagittal deformity. Next slide, please. Coronal malalignments, the most common ones are the idiopathic forms of scoliosis, where you have where you can have juvenile, adolescent, as well as infantile idiopathic scoliosis. That's the large body of coronal malalignment. Apart from that, also, it's important to note that there can also be congenital scoliotic deformities. It can occur as a result of neurologic abnormalities. Neurofibromatosis is also one important cause. Muscular dystrophies are also involved. Post-traumatic issues can also lead to coronal malalignment, and also degenerative causes and infective causes to also form a large part of coronal malalignment. Next slide, please. So, with regards to the natural history, Weston and Ponseti in a landmark paper in 1983, where they analyzed the natural history of scoliotic curves by following patients who had scoliosis up for as long as 40 years. And they discovered that out of all these patients that they followed up, about 68% of these patients with adolescent idiopathic scoliosis progressed beyond skeletal maturity, because this is very important when one is dealing with patients to as regards counseling for treatment and for surgery. And out of these patients, it noted that patients that have thoracic curves greater than 50 degrees tend to progress at an average of 1 degree per year, which is very important, because at this point, you may need to offer your patient surgery in order to forestall or reduce this rate of progression. While patients that had these curves in the thoracolumbar spine tended to progress at 0.5 degrees per year, but they also noted that patients that have curves less than 30 degrees were not likely to progress. So this is important, especially when you encounter a patient at skeletal maturity and you measure the curves and they are less than 30 degrees. It's just a matter of counseling and just observe the patient and let the patient know that it's not likely to progress, but the chances or the benefits and risk with regards to surgery can be discussed with the patient. Okay, so let's go to the next slide, please. Okay, so now clinically, in terms of principles now, when you're talking about principles, you need to do your pre-intervention, intervention, and post-intervention principles. So as we all know, you need to take a detailed history from the patient, and the history has to center around the deformity. When did this deformity, when was it noted, or what happened around the time that led to the deformity? The progression of the deformity, has it been a slowly progressing, or is it a rapid progressive deformity? More importantly, pain is very important to note in these patients, especially in adults, because the pain may be related to the deformity itself, causing axial pain. And in some cases, more common in adults, it may be related to neural compression. And it's important to note that when there's spinal imbalance, meaning that when there's a deformity and the other parts of the spine cannot compensate by altering the deformity in the opposite direction, these patients usually tend to have fatigue-related axial pain. More importantly, in adults, as not too commonly seen in children and adolescents, adults usually have neurological symptoms. They complain of paresthesias, some form of tingling sensation, outright numbness around dermatomal areas or overlapping areas, weakness of the extremities. If it's related to the cervical spine, you find more involvement in the upper limbs and lower limbs. If you have more of thoracolumbar, you find more weakness in the lower limbs. But adults generally don't, they are not usually bothered, not usually bothered, they are not usually drawn to the cosmetic dissatisfaction as opposed to younger children who may be taunted in school or even bullied by their friends as regards the disfigurement of their backs. And some of them, this actually forms a large reason of presenting complaint. In some cases also, where in some other climes where there's appropriate school screening, these children can be picked up at such points. More importantly, in adults, there's also functional dysfunction, where patients may have difficulties maintaining their activities of daily living. They have to use some form of external support. They cannot work for as long as they can. There's the fear of entertaining social guests. So functionally it makes them deprived. Also for adolescents, it's important to note maturity indices because these are key factors in determining the progression of the curve or the potential discontinuation of the curve. And these indices can range from menarche, which is very important in females, breaking of the voice, development of beards, breast development, and growth spots, as the case may be. Now, in trying to find a possible etiology, family history is very important, especially in children and also in adults, because in some cases, you have some adult spinal deformities that are a progression of untreated or unnoticed adolescent deformities. So it's important to also find out if there's any family history, because some cases you may have some familial contributions to this. The pregnancy, birth, and neonatal history is also important. Developmental history, history ruling out infections, possible trauma, and spinal interventions. Okay, it's also important to note prior treatments that patients must have had, which will also, to some extent, help one to know how severe or what complications might have occurred. Okay, next slide, please. So physically, the physical examination starts with when the patient enters into the clinic. You want to note the gait of the patient. Some patients, more common in adults, they list to one side, which may be an evidence of significant disc degeneration and coronal malalignment. Some may stoop forward, which may also suggest some form of sagittal malalignment. They may also be antalgic gait, which is related to pain. The deformity may be such that it has involved significant neurologic dysfunction, which may lead to parathic, and some patients may even be wheelchair ambulant. It's also important to note short limb gait, because in some cases, The scoliosis or the coronal malalignment may be a compensation or a postural adaptation to a short limb. So it's important to note this. And in some patients that have outright structural scoliosis, there's this false perception that they have a short limb gait. So it's important for the clinician to notice this. And also, if you suspect that, to do the adequate examination of the limb length by measuring the real length and apparent length and analyze as appropriate. General examination is also important because there are other conditions, spinal conditions that may present outside of walking or even local back examination. Patients that have neurofibromatosis, we all know the criteria for diagnosing that. They may present with subcutaneous nodules, you find cafe au lait spots, axillary freckles, and the others. Patients that have some form of spinal dystrophism may also have hairy patches over their back. Patients that have post-traumatic deformities, post-infectious deformities may also show signs of sinuses and gibbous over the back as well. And it's important to also do a thorough neurological examination by examining the motor power, sensation, reflexes, tone, and associated supraphyseal reflexes. Next slide, please. Next slide. Okay. So as part of the clinical evaluation, because we are talking about the spine, which ranges from the cervical spine to the sacral region, it's important to examine the back with the patient standing, and then you look from the back, the front, and the sides. And more importantly, when you're examining this, you want to identify the relative heights of the iliac crest and shoulders. And it's also important to note the shifting of the trunk to whatever side. But more objectively, one can use a plumb line, which is dropped at the level of C7, that's the 7th cervical vertebra or T1, and note whatever deviation from that point to the gluteal cleft. And this helps to estimate the extent of clinical imbalance, because in some patients, they may have very bad coronal malalignment, but the spine generally is still clinically balanced because there's some compensation above or below the points of the regions of the deformities. Please, next slide. Next slide, please. Okay, after examining the patient standing and also looking from the sides to ascertain the extent of sagittal imbalance and also compensatory hip or knee flexion, it's important to ask this patient to bend forward so that one can highlight any thoracic hump or lumbar asymmetry as well. Next slide, please. Okay, so this is a picture just trying to highlight, the importance of examination. We can see, looking at the first picture by the left, the shoulder heights are much more prominent by looking from the front. In this patient, you can see the right shoulder is higher than the left. When you look at her from the back also, you can obviously see the truncal imbalance. From the sides, you can see that there's some flattening of the thoracic region, which is documented here as thoracic lordosis. And when this patient bends forward and you examine her from the right also, the rib hump is prominent. You can also look at, you can see the thoracic lordosis more also when she bends forward and you look at her from the left. Next slide, please. This picture depicts the importance of the bending forward, and also you can use the opportunity to measure the axial truncal inclination or axial truncal rotation by using a scoliometer as depicted here, which is placed over the back at the point of maximal height of the rib hump. And then you measure this with respect to a horizontal reference. In this patient, the scoliometer is giving us something in the range of 17 degrees, which is important because in some cases, you may need to take this into consideration when you're operating, whether to also include some form of thoracoplasty or not in order to get good deformity correction. Next slide, please. Next slide. Okay, so now we'll go further into clinical analysis of the coronal and sagittal alignments, both regionally and globally. I know there may be a lot of technical terms, but I must tell you that spine deformities are, in some cases, and they're not even for beginners, it's for the masters. So trying to bring everything together today is just a way of whetting our appetite so that we can all, for those that are interested in spine, they can be stimulated to read further. Okay, so talking about the coronal alignment regionally, one can measure this or ascertain this by looking at the patient and measuring what is referred to as the shoulder tilt angle, which is obvious in this diagram, where a line, a horizontal line, is drawn across the left and right coracoid processes. In this patient, in the first slide here, the first diagram here, you can see that this patient is balanced, while on this side, where there's a tilt or an asymmetry of the shoulder, one can see the shoulder tilt angle, which may also suggest to one the extent of regional deformity. Like I mentioned earlier, the angle of truncal inclination is also important. These are clinical measurements of the effect of regional spinal deformity. So it's important for you to note this, especially when you're talking about regional correction. This don't have any meaning, or if you're thinking of balancing the spine globally, you may overlook this sometimes, but it's important to document this for research purposes as well. Next slide, please. Okay, continue with coronal alignment measurement radiographically. It's important, especially for coronal malalignment. There are some terms that need to be defined. And when you look at an X-ray, you find there are some terms that many of us would have heard and may not be very clear, which are referred to as the end vertebrae, the neutral vertebrae, the apical vertebrae, and then also we have the stable vertebrae and the touch vertebrae. And there's also the Cobb's method of measurement of angles. So I'll start by defining what the end vertebrae is. The end vertebrae should be defined for all coronal curves because this actually defines the beginning and ends of the scoliotic curve. And for any scoliotic curve or coronal malaligned deformity, the end vertebrae, you have two end vertebrae. That's the upper and lower end vertebrae. The upper one, as the name suggests, is the most cephalad vertebrae that maximally tilts into the concavity. Sometimes a shortcut of knowing which is the end vertebrae is you look at the disc, the intervertebral disc. If we look at this intervertebral disc up here at the upper end vertebrae, you see that above the upper end vertebrae, the disc starts opening onto the opposite side. Whereas on the other side, this is the last point where you have the disc opening onto the convexity. So when the disc starts opening away from the convex side, that area is where you should start looking out for where your end vertebrae is. Likewise, also when you go distally too, you see that on the opposite side, on the concave side of the curve, you see the disc is opening more at this level. So here will be your end vertebrae. It's just a shortcut, or how should I put it? In some cases, you may not have very clear radiographs, and you may not have this sort of annotated diagrams. So it's important, but more importantly, one needs to know that the end vertebrae are the vertebrae that tilt most maximally. In some books, they may even go ahead to tell you that it's the most tilted and least rotated vertebrae along the curve. Now you also have the apical vertebrae or disc. And the apical vertebrae is the most horizontally and laterally deviated vertebrae. Like if you look at this curve now, sometimes it could be the disc, it could be a vertebrae that is obviously most lateral. And it looks horizontal, it doesn't look rotated. So at that point, it looks horizontal, so to speak, but it is actually the most rotated part of the curve, because it depicts like the fulcrum where the deformity started from. Now you have neutral vertebrae. These neutral vertebrae, as the name suggests, they are vertebrae that don't show any form of rotation. There are many ways of identifying rotation. I won't bore us with that. There's the Nash and Moe method and the Pedrell method of identifying rotation. But more importantly, once we've defined our end vertebrae, upper and lower, we draw lines along the inferior end plates of the lower and superior end plate of, the inferior end plate of the upper and the superior end plate of the lower. And then we measure the curves, the angles there. That is what is defined as the corpse angle. Because in some cases, you may not have a large radiograph that you can draw these angles and meet. So a shortcut or a mathematical principle is that when you draw those lines above and below, you draw perpendicular lines to them, where they intersect is also equal to this angle here. So that's the corpse method of measuring of coronal angles. Okay, next slide, please. Yes. Okay, so in continuation, there's what is also defined as the central sacral vertical line. And this is a line that touches the highest points of the iliac crest. That's the first line you draw. And then also, after drawing that line, you draw another line that bisects the sacrum and is also perpendicular to this. That second line you draw is referred to as the central sacral vertical line. It is important because it helps you to highlight what is referred to as the stable vertebrae. The stable vertebrae is critical in determining lower end vertebrae that will be instrumented, otherwise referred to as your lower instrumented vertebrae, when you want to talk about instrumentation and surgical correction. And the stable vertebrae is regarded as the vertebrae that is almost nearly bisected by the CSVL. If we look at this diagram here on the left side, you can see that this L5 is bisected, L4 is bisected, L3 is almost also bisected, but L2 is not. In fact, there's also the concept of the touch vertebrae, because there's a principle of trying to fuse as little as possible. So some people also have the concept of touch vertebrae, that is the vertebrae that is just merely touched by the central sacral vertical line. In some cases, can also be used as your lower instrumented vertebrae. So all these principles are important for one to note when you're evaluating the patient, so that you can decide if a patient needs surgery, where you want to stop your instrumentation distally, and if the patient doesn't need surgery, what else you want to do for the patient. But it's important to document this also for research purposes. Next slide, please. Okay, so using the Cobb's method, there are various angles you can measure coronally, from the occipital-cervical curves across the cervicothoracic junction, the proximal thoracic, main thoracic, lumbar curves, and all that. So now that one has an idea of how the Cobb's method of measurement is done, you just measure along the superior end plates of the superior end vertebrae and the inferior end plate of the lower end vertebrae. Okay, so next we'll also talk about global coronal alignment. This is ascertained by measuring the head tilt, and in this case, you look at the interpupillary angle. In some patients, it's just by drawing an imaginary line across the centers of both pupils and estimates to how much deviation it is from the horizontal plane. This is a clinical measurement of ascertaining total coronal deformity, and its importance is on horizontal gaze, because as it stands to reason, if a patient has a remarkably deviated interpupillary angle, it may affect the patient's ability to perform horizontal gaze. Next slide, please. Also, radiographically, there's the term known as the apical vertebral translation, which is just to ascertain how much of translation the apical vertebra or disc is from the midline. And this is ascertained by estimating the distance between the apical vertebrae and a plumb line drawn from C7. You also want to ascertain how much of that is also moved away from that C7 plumb line to the CSVL, and that gives you the C7S1 coronal vertical axis. There are many lines and measurements that can be done, But I must tell you that it's not every time that you need to do all this, and there are many values from different researches. So what is more important is for you to use this to guide your outcome after surgery, most likely, to see how much of correction these patients have gotten, especially after doing surgery. Next slide, please. Next slide. Okay, so because we're talking about coronal malalignment, it's important to discuss the Lenke classification of adolescent idiopathic scoliosis. And the Lenke classification has three major parts. There's the morphology, that is the curve type, which is further divided from Lenke 1 to 6. And then you have lumbar spine modifiers as well as thoracic spine modifiers. And the Lenke 1 to 6 is dependent on the terms of which curves are structural and non-structural. Let me just try to make this as easy as possible. Now, the spine, the thoracolumbar spine, is divided into three major parts. That's the proximal thoracic spine, the main thoracic spine, and the thoracolumbar lumbar spine. And what divides them is such that where you have a curve between T3 to T5, it's regarded to as the proximal thoracic. When there's a curve from T6 to T12, it's regarded as main thoracic. When the apex, rather, is between T6 to T12, please, I beg your pardon, is regarded as main thoracic. And then when you have the curve spanning from T12 down to L4, it's regarded as thoracolumbar lumbar. Now, first and foremost, after measuring these curves, whichever of these three regions has the highest magnitude or the highest number is referred to as the major curve. And by principle, the major curve is always regarded as a structural curve. We'll see pictures later, but let me just try to define this now. So after defining the major structural curve, the next thing to determine is if the minor curves, that is the curves that are non-major, whether they are structural or non-structural. And there are criteria, structural criteria for determining whether these are structural curves or not, because sometimes these curves may develop as compensatory curves, and over time, they progress to become structural. So, and if they are structural, one must include them if you're going to do your surgery. And if they are compensatory, if you include them in your surgery, you're just going to cause an imbalance of the spinal alignment, because if something is compensating for the structural deformity, it starts to reason that if you add it into your surgical correction, you're going to cause more harm than good. So please, next slide, let's talk about so this is just a table showing the description of the curve types: the main thoracic, double thoracic, Lenke 2, double major, Lenke 3, triple major, Lenke 4, and the table is explicit, so we can all look at it afterwards. Next slide, please. So these are pictures showing Lenke 1. If you look at this X-ray by the far left, you see the figures in brackets are the curve magnitude on bending. So this is the proximal curve, which is 38 on standing. It reduces to 21, which is for the structural criteria, it must be greater than 25. So this is a non-structural curve. Here you have 49, it reduces to 4. But here there's something peculiar happening here in the main thoracic. The main thoracic curve on standing is 57, but on bending is also 18, which is less than what is agreed for definition of structural curve. But in this case, don't forget that we said that every curve, the major curve, that is the curve that has the highest magnitude, is always regarded as a structural curve. So in this case, it's only the main thoracic curve that is structural here, while the others are non-structural, and this gives us a Lenke 1. In Lenke 2, we have double thoracic. The proximal thoracic and main thoracic are structural. In Lenke 3, we have double major. That is the main thoracic and the thoracolumbar are structural. Please, let's move to the next slide. I've been told that my time is running out fast. So this is Lenke 4, which is regarded as triple major. The proximal main thoracic curves are structural as well as the thoracolumbar lumbar. In Lenke 5, you have the thoracolumbar lumbar structural curve. And in Lenke 6, is also like a double major curve, but in this, you have the thoracolumbar lumbar curve being the major curve, major structural curve, while the main thoracic is a minor structural curve. Please, let's move on. Next slide. Now you have the lumbar modifiers, and you have the lumbar modifier A, where the CSVL runs in between the pedicles at the apical disc, which is shaded here, while you have lumbar modifier B, the CSVL merely touches the apical pedicle, and in lumbar modifier C, you have it far outside the apical vertebrae. These are radiographs to highlight that. Next slide, please. Next slide, please. Now you have the thoracic sagittal modifier. Because scoliosis is referred to as a hypolordosing deformity, one needs to know the extent of kyphosis that is present in the thoracic spine, such that if you're going to correct them, you don't want to create, your correction will aim at introducing some kyphosis. So if a patient already has some background kyphosis, introducing more kyphosis will worsen it. So it's referred to as minus, neutral, and positive. When the angles are 10 degrees or less, it becomes minus, because usually the normal thoracic kyphosis is between 10 to 40 degrees, which is neutral in this second image. And then on the last image here, by the right, is hyperkyphosis. Next slide, please. Yes, for adolescents, you also want to evaluate skeletal maturity by the commonest way of ascertaining that is using the riser scale, which divides the iliac apophysis into 4, and then you want to see how it's going from lateral to medial, which helps one to determine the extent of skeletal maturity. You also look at the opening of the triradiate cartilage as well. You can also look at the extent of ossification of the fingers, but much more reliably to ascertain extent of skeletal maturity is the presence of the olecranon epiphysis. Next slide, please. So we talk about curve progression in adolescents, and the best measurement of this is the peak height velocity. And like I told you, the presence of the olecranon, if you have a patient who does an elbow X-ray, and you can see the closure of olecranon apophysis, it tells you that that patient has already gotten to the point of peak height velocity, because this helps to determine whether you want to put the patient on bracing or you want to go ahead with surgery. Skeletal maturity is usually regarded as riser 4 or above. When you continue to see this patient serially in the clinic and there's less than 1 centimeter change in height. And for females, generally 2 years after menarche, is assumed that they are skeletally mature. And it's important to note that curve progression, patients that have curves greater than 20 degrees at peak height velocity are more likely to rapidly progress, and also patients who have curves greater than 40, 50 at skeletal maturity are also more likely to progress. Next slide, please. So sagittal alignments, I won't say so much about this. There are different regional measurements that can be done as depicted. Next slide. The thoracic kyphosis also, you can get the total proximal main thoracic or thoracolumbar measurements as well on the sagittal views. Next slide, please. As well as the lumbar, lumbosacral lordosis, yeah, they are all depicted there. It's just the same principle using the coronal. And then more importantly, I would like to state that there are no hard and fast measurements or values that should be gotten for thoracic kyphosis with respect to lumbar lordosis. But it's important to note that generally lumbar lordosis should be at least about 30 to 40 degrees higher than thoracic kyphosis in order to balance it out to get a well-aligned sagittal alignment globally. So it's important to note that so that we don't go looking for definite values. So we'll talk about the pelvic incidence. The pelvic incidence, there's the concept of the sacropelvic alignment as well, which is very important because some authors believe that the pelvis is actually regarded as the pelvic vertebrae, because you can't do anything in the spine without considering the pelvis. So there's a concept of the pelvic incidence, which is unique to each human and increases during skeletal maturity. And at the point of skeletal maturity, it becomes a constant value and is measured from the midpoint of the femoral heads, drawing a line there to the midpoint of the of S1, and then checking the angle between that and another line drawn from the midpoint of the sacrum perpendicular to that. It's all depicted in the description here. So that is regarded as the pelvic incidence. The pelvic incidence is related to the lumbar lordosis. And the lumbar lordosis and pelvic incidence, there shouldn't be more than 10 degrees difference between them, because the pelvic incidence is usually viewed like the takeoff of the lumbar spine, like a plane is taking off. So if the pelvic incidence is large, you expect the lumbar lordosis to be large, and otherwise as well. Next slide, please. You also have the pelvic tilt and as well as the sacral slope. These are parameters that can change dependent on posture and pathology. And the pelvic tilt is measured by drawing a line from the midpoint of the sacrum to the midpoint of the femoral head and relating it to a vertical reference line. And so when you have the pelvic tilt with retroversion and anteversion of the pelvis, it changes, it varies. If there's retroversion of if there's anteversion of the pelvis with the sacral midpoint moving closer to the vertical reference line, the pelvic tilt reduces. And if you have retroversion, it will increase. So it's important to note this, because these are parameters that can be played around with in order to ensure that the spine is balanced. Next slide, please. Next slide. So this is just a picture trying to depict the changes of the pelvic tilt with version of the pelvis. As you can see in A, this is the pelvic tilt with this patient not balanced. As the patient retroverts the pelvis, you begin to see the pelvic tilt increasing up to this point. So these are compensatory mechanisms. Imagine if the patient has some deformities here, so the patient will need to retrovert the pelvis in order to get a large pelvic tilt to balance the spine. Next slide, please. You also have the sacral slope, which is the angle subtended between a line along the sacral end plate and a horizontal reference line. It's important to note that the sacral slope and the pelvic tilt, when you add them together, they usually give you the pelvic incidence. So if there's retroversion, if there's increase in pelvic tilt, it stands to reason that constant pelvic incidence, and also otherwise. Next slide, please. So this is just a picture showing everything together to depict the relationship between the three. Next slide, please. So clinically, global sagittal alignment is important to note the chin-brow vertical angle as seen in this picture. A patient that has some sagittal malalignment, you can see the extent of the chin-brow vertical angle, which is so large here. Normally, it should be neutral, and this is a clinical measurement of determining the impact of the sagittal deformity on horizontal gaze. Next slide, please. Next slide. So these are also radiographic parameters of determining global sagittal alignment. Please, next slide. You have the C7S1 sagittal vertical axis, which there is no general consensus as to what the value should be, but most people generally aim for a C7 SI SVA less than 5 centimeters to ensure that the spine is globally balanced sagittally. Next slide, please. Some authors have talked about the T1, T9 spinopelvic inclination, which is said to be more reliable than the C7 SVA, and they're depicted as shown there. Next slide, please. So treatment, what are the primary treatment goals? The aim of treatment is to halt deformity, relieve pain, and improve function, especially in adults, because in adults, the amount of cough correction is not so important to them as much as a stable, balanced, and pain-free spine. So the options of treatment are basically conservative or palliative treatment, which can be done via physiotherapy, braces, and medications. Braces more important in adolescents, not very useful in terms of treatment rather than palliating in adults. Surgical treatment, and in some cases, less invasive neural decompression surgeries. Next slide, please. Next slide. So in terms of braces, there are different types of braces that have gone through evolutionary changes. You have the Charleston braces, the Wilmington braces as depicted there. Next slide, you also have the Milwaukee brace and then the Boston brace as well. But more commonly what we use is the Boston brace and is indicated for adolescent coronal deformities with apex at or below T8. Next slide, please. You also have the GWET hyperextension device, which is more commonly used in patients with post-traumatic or post-infective sagittal malalignments. Next slide, please. So now, if once a patient has been seen and you've evaluated the patient and you suggest you're thinking of surgery, but generally, plain radiographs come in handy to evaluate these patients, and you need to get plain radiographs in AP and lateral plane. For coronal deformities, you may ask for lateral bending films, and in some cases also, you may ask for overextension over a bolster, bending over a fulcrum X-rays. In some cases, one can also do traction X-rays also. These are just aimed at seeing the flexibility and extent of correction of the curves. If spondylolisthesis is suspected, one should request for standing flexion extension lateral films in order to ascertain the stability of the translational deformity. Next slide, please. So preoperatively, you can ask for computed tomography scans, MRIs to further analyze neurologic and osseous parameters of the spine. For older patients, you can work them up for surgery as indicated and rule out infective processes. If there's a need for biopsy, if you're thinking of malignancies also, that can also be thought of preoperatively. Next slide, please. Next slide. So in terms of deformity correction, one needs to ascertain the presence or absence of spinal imbalance. And your aim of correction can vary from whether you want to have a balanced global correction or you want to have, in addition to that, complete correction both in coronal, sagittal, and axial planes. And in doing that, you need to review and ensure correction in all these planes together and not in isolation. Next slide, please. So generally, what one usually aims for is to obtain a balanced spine as much as possible, such that you can get solid fusion over time in order to prevent further deformity. Next slide. So in doing this, there are some parameters you would want to keep at the back of your mind when you're going in for surgery. You want to ensure that the pelvic incidence lumbar lordosis discrepancy is less than 10 degrees. You want to align the sagittal vertical axis to as much as less than 5 centimeters, and you want to get the pelvic tilt to as much as less than 20 degrees so that the patient has a large room for compensation if there's need for that subsequently. And like I said earlier, you want to make sure that the lumbar lordosis with respect to the thoracic kyphosis is also not less than 30 degrees in terms of the difference. Next slide, please. So this is just a diagrammatic depiction of the goal of surgery. Next slide. Okay, so these are radiographs showing a patient who had a pelvic incidence of 65 degrees, pelvic tilt of 43, C7 sagittal vertical axis of 21 centimeters. And you can see that this patient obviously is not balanced. And after surgery, where he had extensive spinal instrumentation and interbody fusion at 2 levels, you can see that even though the sagittal vertical axis is not less than 5 centimeters, which is general advocated, but you can see the far reduction from 21 to 7 centimeters. You find the pelvic incidence is still 65 degrees, but the pelvic tilt has reduced to 27 degrees. I'm not sure if you can all see that. And you can see the lumbar lordosis is 65 degrees, which is almost identical with the pelvic incidence. So for this patient, even without knowing anything in spine, you can see that the patient is globally balanced. Okay, next slide, please. So preoperative workup, you need to counsel the patient, let them know that it's a high-risk surgery, discuss with the patient's family informed consent as much as possible, antimicrobial baths, and all what that is written there. Next slide, please. I need to rush now because I think my time is up. Next slide, please. Okay, operative principles, you need to determine when you want to operate, adolescents versus adults. Like we said earlier, we discussed about the skeletal maturity, which will help one to determine when you want to operate adolescents. For adults, it's basically after working them up for surgery and ruling out optimizing comorbidities. The approaches and positioning matters. You want to do anterior or posterior or some form of lateral modifications. Bone graft and substitutes needed in order to ensure solid fusion. Next slide, please. So this is a picture showing the posterior positioning for a posterior approach, which is the workhorse of orthopedic spine surgeons. Next slide. It's important to note that you need a neuromonitor for these cases because of the attendant high risk of neurologic injuries. But where you don't have a neuromonitor, you can also make use of the Stagnara wake-up test, in which anesthesia is decreased at a certain point in surgery, most especially after you've done some osteotomies or you've done some manipulation of the spine. Patient is brought to a conscious level and you want to ascertain movement of the extremities. Next slide, please. So the implants and instrumentation, we basically, in this generation, we use the tricolumnar pedicle screws. In the past, hooks and Harrington distraction systems have been used, and then the materials that can be used are also listed there. Preferably, you can, if you have the wherewithal, you can use cobalt chrome materials, but titanium implants are usually what most people use nowadays because of its relative advantages with as compared to stainless steel. Next slide, please. So there are different correction techniques, especially for coronal deformities. Largely, one tends to use the total rod derotation technique, which is noted in this picture by your right, where after putting in your pedicle screws and bending your rod, usually the concave side is overbent, and then you derotate away from where the curve is convex towards, whilst your assistant gives you some form of counter pressure on the other side. So when you can use this technique, you can also use the differential rod contouring technique as well. Next slide, please. You can use the M-block derotation where specialized instruments are used, and the deformity is divided into different regions, which will be derotated against each other. Like if you see in here, the proximal part, the middle part, the lower part, there are different points. So the middle part is derotated inwardly, while the proximal and distal parts come in the other direction in order to get a balanced spine, which is seen here. Next slide, please. You also have the cantilever technique, which comes in handy, especially for patients that have severe kyphotic deformities, where you mount your screws and your rods proximally, and you use a cantilever technique to sort of correct the sagittal deformity. Next slide, please. There's also room for traction, and traction comes in preoperatively, especially patients that have very bad deformities, coronal malalignments greater than 100 degrees, and you want to get some reduction and flexibility of the spine before you go in for surgery. So you can apply halo devices, and the patient can have a traction device that can also allow the patient ambulate within the ward. Next slide, please. So other techniques that can be used for correction include the compression, distraction technique. You can use the direct vertebral body derotation, and as listed, advanced techniques in spine surgery. Next slide, please. Now, more importantly, also, there's room for osteotomies, because it's not all spinal deformities that are flexible and that are rigid to allow you do some form of soft tissue release and deformity correction. And in these cases, you need to carefully select your patient and work them up for osteotomies because these have a higher tendency for neurologic injuries. So osteotomies can also be done in spine, and they range from different grades from grade 1 to grade 6 as defined by Schwab and Blondler. Please, next slide. And this grading is also dependent on how much bone you resect. As you can see, they are labeled A, B, C, D, E, and as they are grade 1 to 6. Grade 1 to 6. So for this, you have the partial facet resection for grade 1 as compared to the spectrum where it ends at grade 6, where you have multiple adjacent vertebral body resection. Next slide, please. Next slide. Okay, sorry about that. I think there was some internet malfunction. So we'll talk about the Ponte osteotomy, as seen there, is referred to as a grade 2 spinal osteotomy. It can give you as much as 5 to 10 degrees of angular correction and was named after Alberto Ponte, primarily used for Schwann's kyphosis, but now due to its versatility, we use it for virtually any form of spinal deformity that you encounter. Next slide, please. You also have the Smith-Peterson osteotomy, which is usually confused or similar to the Ponte's osteotomy. And it's usually reserved for spines that develop some form of ankylosis or autofusion. Is indicated in ankylosing spondylitis. It's also a grade 2 spinal osteotomy as well, where you have resection of the inferior and superior facets. You have resection of the spinous process and lamina, adjoining lamina, as well as the interspinous ligament and the ligamentum flavum to allow correction. Next slide, please. You also have the pedicle subtraction osteotomy, which allows, as the picture shows, you take a wedge through the pedicles into the vertebral body. It's like a closing wedge osteotomy, and it can allow for as much as 30 degrees of correction. Next slide. Next slide, okay. And then we have the vertebral column resection. You can resect as much as 1 or 2 or 3, but you should note that with each resection, there's likelihood of increased manipulation of the neural elements, and this can portend a very bad outcome. So it's important that this 3-column destabilization should only be reserved for spinal deformities that really need it. And next slide. Next slide. Okay, so this is just a table trying to summarize the upper instrumented and lower instrumented vertebrae when you're dealing with adolescent idiopathic scoliosis. I won't bother us with a lot of this. I think we can get the slides and just, it's well informative, but it's just important to note that for the upper instrumented vertebrae in adolescent idiopathic scoliosis, you usually stop at T2 when there's a slight left shoulder elevation. When the shoulders are equal, there's no asymmetry, you can stop at T3, T4. But when the right shoulder is higher than the left, you stop at, you have the option of stopping at T4, T5. And then the distal end instrumented vertebrae can be read up here with respect to the stable vertebrae and the end vertebrae. Next slide, please. Next slide. Okay, so post-operatively, your post-operative principle starts from in the theater, the recovery room. You want to evaluate the patient again to be sure that whatever neurological dysfunction the patient had before is not worse after surgery, so that whatever intervention you can do, you can do that there. Medications as necessary, physiotherapy postoperatively, wound care is important. There are different schools of thoughts about inserting drainage or not. We preferably do that. Bracing also, whilst the spine is undergoing the process of fusion. You may also want to manage complications as they arise, where we don't hope for them to arise. And then you discuss return to activity and lifestyle modification with the patient. Next slide, please. Complications that can happen maybe intraoperatively from incidental durotomies, vascular nerve or nerve injuries, inadvertent pedicle fractures. Postoperative complications too can happen. Next slide. And this can also range from reactionary hemorrhage, infections, wound-related, implant breakages, implant-related, failure of fusion, and also more importantly, adjacent segment disease, where areas that were not fused above and below can also develop some degeneration and post-generation deformity. Next slide, please. So these are just radiographs showing some of the works we've done here. This is a patient that had pyogenic spondylodiscitis. If you see preoperatively, you can see the reversal of cervical lordosis here, tending towards kyphosis. And this patient had 2-level corpectomy with insertion of a fibular graft and anterior cervical plate and restoration of the cervical lordosis. Next slide, please. You have this achondroplastic patient that had multi-level vertebral column resection at the thoracolumbar region, T12, L1, L2. And you can see the restoration of the spinal alignment, the global spinal alignment to some extent. Next slide, please. And then you see this patient with adolescent idiopathic scoliosis post-surgery with significant reduction and decrease in the coronal malalignment. Next slide, please. So clinical take-home messages is important for us as clinicians to know that spinal deformities is a large area in spine surgery. I'm even wondering how I was able to cover all this within the time allotted to me, or not, although I know I shot beyond that. But it's important for us as clinicians to know that in adolescents, more importantly, the curve progression and cosmesis is important, while in adults, pain and neurologic abnormalities is more emphatic in them. Adolescents usually have less rigid curves, and as such, it's the technicality in terms of correction is less, and complication rates are usually less as opposed to adults. And in adolescents, you may require some form of bracing to modify curve progression, while in adults, there's usually no role for bracing in terms of curve correction. Okay, thank you very much.
Thank you very much, sir, for the presentation. That was a presentation on the principles of deformity correction in spine surgeries. I earlier asked in the group if we have questions, please. Can we kindly indicate by show of the virtual hand? A comment in the chat box from the medical director is noted with thanks, sir. Sir, I just have one question. Is there room for staged corrections in spinal deformities, sir? Could certain deformities be corrected sequentially, sir? Would entertain questions. We have just 5 minutes to do that. And this program is almost coming to an end. We want Philips Pharmaceutical to please share their screen and prepare for their presentation. Thank you, sir.
Okay, in terms of staged correction, you have to determine what exactly you want to correct and which area of the spine is really causing or is responsible for the onset of the deformity. Because like I said earlier, you may have compensatory deformities as well as the structural deformities. So if you want to stage your correction, don't forget that you are going to increase the extent of surgical exposure and the likelihood of neurologic injury and neurologic manipulation. That being said, you also need to take into consideration your patient in totality, your patient in terms of fitness for surgery, how much extensive surgeries they can get, whether you want to do some now and then come back later, or what is the essence of your surgery? Do you just want to decompress the neurologic elements for a while, whilst still supporting externally, maybe with some form of orthosis in terms of the spinal instability and allowing a little bit of correction of the deformity? So this is a question that will be individualized. If you have patients that are not too fit for extensive surgeries, and then you don't have the wherewithal or the requisite monitoring devices, you may want to stage it to some extent. But largely, if you are going in and you've optimized your patient, it's best for you to do as much as you can so that you don't need to come back to the spine again to do any form of manipulation or correction. So that, I think that's the way I will approach that. So there's no hard and fast rule with regards to stage correction. You just have to relate it to the individual patient. Hello?
Thank you very much, sir.
Hello?
Yes, sir.
Yes. Yes, so I hope you got what I said. So that's my own opinion about it. I know I have a spinal surgical elder in the group, so he may want to throw a little bit more light on it, sir, in person of the medical director. But before that, I would just like to thank the ARD for giving me this opportunity, and I must apologize that I shot beyond my time. As you can see, spine deformity is not, it's not, even if we are given the opportunity to discuss congenital scoliosis, we may still go beyond our time, let alone try to bring all the principles together. So I hope I've not confused a lot of people, but if you have any questions outside of this forum, please feel free to ask. Thank you very much.
Thank you very much, sir. Again, fantastic delivery. The comments from the medical director. We thank you very much, Dr. Idowu-Deifa, for the presentation. I'm not seeing any other hands. This presentation has been given by the consultant, a spine surgeon. I have a hand, maybe we'll just take that. And if the medical director so wishes to give us some words of wisdom on this topic, we would appreciate. The hand has been lowered. I can't see the hand anymore. Philips Pharmaceutical, please could you share your screen? Mr. Ejike.
Yeah, good afternoon, everybody.
Yes, sir. Thank you very much. You have the floor.
Okay. My screen is visible. Yeah, good afternoon, everybody. My name is Ejike Asowa. You can also call me Ketes or Fastum Gel, which you all know. In terms of this presentation, I want to present one of our newest products that is indicated for the chronic venous diseases of the lower limbs. As the name implies here, which is Minavel, is a gel formulation. We call it Minavel Gel 1000 IU. So as we all know about why we delve into chronic venous diseases, which comes as a result of incompetent venous valve. Sorry, I'm coming. Sorry. So as a result of incompetence, can you hear me?
Loud and clear, sir.
Okay. So before I go further, I want to use this diagram to explain everything about the chronic venous diseases and the pressure that occurs in the lower limb of the normal person and the lower limb of a patient with incompetent venous valve. As you can see in the diagram, that during standing and walking, you have different types of pressure. In a normal limb, when the patient is walking, the pressure is supposed to come down well. But in patient with incompetent valve, there is a high pressure, either the patient is walking or sitting down, which leads to a lot of clinical aspects like the capillary leakage, edema, inflammation, venous ulcer, and skin changes, which one of these products can effectively manage the symptoms as listed here: heavy legs, swollen ankles and extremities, leg itching, cessation of widespread soreness of lower limb, nocturnal cramps, and telangiectasia. Our products can effectively manage these symptoms associated with venous insufficiency in chronic venous diseases. Also, these diseases are manifested in this diagram, like the venous varices, skin dyschromia. So when you see a patient with this type of skin diseases, every doctor can now manage it using our products. It's a topical and it can easily be applied. No need referring to an expert in this. Since it's a topical, once you see this, you can prescribe the products immediately, can effectively manage these conditions. So the product has the active component heparin, but it comes in topical form. Heparin comes into play in this product because of its the role heparin plays in blood coagulation cascade in preventing formation of thrombus. So that the anticoagulation effect can also happen superficially in patients with chronic venous diseases. Sorry, my network is, can you hear me?
Very well, sir.
Okay. My slide cannot move because the network now is there. So going further.
I need to share your screen again, sir.
The screen there, the network is fluctuating. So, but I can
maybe
go on
share
further.
It again, it has gone off. All right.
Yes, I will share it. I will share it. But because of time, let me keep talking. So the active components in this new product is heparin, as I said earlier, because of its anticoagulation effects in the system, which can also happen superficially in patients with all these chronic venous diseases. So a lot of studies have been done on these products, and various disorders had been used in these studies, like all the forms of venous diseases of lower limbs, such as the varicophlebitis, superficial thrombophlebitis, periphlebitis. All these have been done scientifically and discovered that this new product called Minaven is a good therapeutic option for the management of these diseases when applied 3 times daily for 20 days. Like in superficial phlebitis, when applied twice daily for 14 days, the patient will be okay. In thrombophlebitis, is applied twice daily for 28 days. Then in varicophlebitis, can be applied 3 times daily for 30 days. So in those, some of these different cases have different ways of application, and the patient will get a very good result at the end of the whole treatment, at the end of the treatment. Even in chronic venous insufficiency with lower limb ulcer, when applied once daily for 30 days, the patient will get relief. Even in venous catheter phlebitis is also very, very okay. Please don't permit me to log in again. I don't know what's happening to my network, so that you see this, the end of the slides. Hello, is my screen there?
With you? Yes, your screen is coming up now. It's up, we can see it. You can carry on, sir. You have just a few more minutes.
15?
A couple of minutes. No, sir. You had
Okay.
a total of 10. You've used up 7.5, so you have 2.5, sir.
Let me go straight to the. So as I said earlier, you can see the product is called Minaven Gel 1000, in the sense that each gram of the product contains 1000 IU of Minaven, because study shows that the higher the quantity you apply, the better the efficacy, because it has to do with skin absorption. The skin will absorb it and accumulate on the layers that are being needed. So the higher the concentration, the higher the efficacy. So Minaven is a sodium heparin-based topical formulation. It has a very high heparin concentration of 100,000 IU per 100 grams, which makes this formulation an effective transcutaneous treatment of chronic venous diseases of varying severity. It has a unique carbomer-based gel formulation, which provides it with optimal cosmetics with cooling effects without any stain. It has a very pleasant smell also, with an essential neroli and lavender oil for cosmetic. This is a dose-dependent skin absorption, as I said earlier. The skin absorption of after repeated exposure increases its efficacy. Then study have been done on its use in superficial venous diseases, and as I mentioned earlier, superficial phlebitis and superficial thrombophlebitis, varicophlebitis, and the venous catheter also. Then, in summary, the scientific features of these products is a pure heparin and its high heparin concentration with optimal vehicle. So it's widely used for prevention and treatment of local symptoms of peripheral vascular disorders, such as venous insufficiency, varicose veins, and superficial thrombophlebitis. Clinical studies on heparin gel in patients with chronic venous disease show that topical application of sodium heparin is effective in reducing signs and symptoms of all these peripheral vascular diseases. It has also been shown that Minaven is more efficacious than similar preparation of heparin-based topical products with same indication, probably because of its original formulation with a higher content of heparin concentration. It's safe. The systemically is safe, and it has a local safety in good clinical trials. So topical transdermal treatment with Minaven or superficial venous diseases or lower limb has a favorable efficacy and safety profile. So the key points I want you to know is that it has an excellent penetration, reaching the optimal dermal concentration, good efficacy in various disorders, and small traumas. It can also be used in small traumas to reduce edemas, pain, and hematomas. It's well tolerated both locally and systemically without interfering with the coagulation and prothrombin time. Is a high quality gel with pleasant fragrance, refreshing feeling, no stain, no grease mark, synergistic activity with the systemic forms, is indicated for superficial venous infection, varicose syndromes and their complications such as phlebotrombosis, thrombophlebitis, superficial periphlebitis, varicose ulcers. In varicose ulcers, when you rub it around the wound, it restores normal micro blood circulation around the wound to have an effective healing. Post-operative varicophlebitis. In traumas and contusion, as I mentioned earlier, such as the infiltrates and local edemas. Thank you.
Thank you very much for that beautiful presentation. Floor is now open for 2 questions only. 2 questions. Sorry, sir, you didn't already answer the common question. We would like to know how much this will cost. And then I particularly have a concern with the use of heparin, because this is the unfractionated heparin that is in this preparation. Systemic toxicity can occur from it, even though it's topical preparations. Are these patients meant to be monitored? At what point do we stop? And other concerns. I don't know if you can quickly address those while we wait for any other question from the floor. Thank you.
Okay, as like the diagram showing here is one of the studies that have been done on the coagulation parameters. In prothrombin activities, there's no significant change after 30 days. In a PTT also, from the baseline, it has no significant, no systemic effects after 30 days also. So the patient don't need to be monitored. It's a topical application. Once the patient apply it, in some cases twice daily for 30 days, some cases once daily for 14 days, the patient is good to go. That's why I say that any doctor can manage all this condition now with Minaven, because it's topical and the safety profile is very high.
The cost?
The cost from us is 2,800, but in pharma institutions like Igbobi, we still give some percentage discount so that patient will get it cheaper.
Okay, thank you very much, sir. Please, I recognize the presence of Dr. Mrs. Abikwe, the head of Department of Bones, Plastic and Reconstructive Surgery. Thank you.
Thank you for the presentation. I just have my concerns, yes, concerning your blanket statement as per the use of Minaven to heal chronic leg ulcers. I think venous insufficiency. I think in healing this ulcer, you have to look at the underlying pathology. And from the mechanism of action of Minaven, you said that is to address thrombosis in the vessels. Yes. So, but for venous insufficiency, you have more problems, which is the valvular problems, the problem at the level of the valve. So that needs to be addressed too. So it may be an adjunct to maybe just to improve it to some extent, but there are other things that you should address. That's why you can use it for other kinds of thrombosis. When you have thrombosis or the telangiectasia, those are the various stages of the chronic venous insufficiency. But to really address when you have the chronic ulcer, it may become an issue for it to actually help you. It can only improve, but it's not that alone. If you keep using it without supporting that limb, yes, the patient will keep spending money, but the valves are not supported. So there's a need for appropriate person to guide this person, not just selling that product, but it can be used with as an adjunct to other treatment that will be given. Thank you.
Thank you, Ma. I really agree with you. But the major thing is what the patient suffers mostly, like the symptoms which I mentioned here, to control the leg itching, the pains, the inflammation, he expresses the heaviness of the legs and everything. just to control it. I didn't say it can only be used.
Well, the truth is that it may not address all this. That's what I'm saying. It may not address all this when you have the ulcer, because there are other things causing it. It will act on the vessels there, but the itchiness, there are other things, the pathophysiology of the ulcer forming. So it may not address all those features. Thank you.
Yeah. Thank you, ma. Thank you very much, ma.
Thank you very much, sir, for this presentation. Thank you for your time and for giving us this wonderful presentation. You may please stop sharing your screen. Thank you, distinguished ladies and gentlemen. We've come to the concluding part of this scientific conference. It's been a long day and we really appreciate you for your time. All our elders in the house, trainers, consultants, nurses, physiotherapists, and all participants of this event, we thank you. We would want to have a vote of thanks from the Vice President of the ARD NOHIL. He is also doubles as the local organizing committee chair of this OGM and scientific conference. Dr. You have the floor.
Good afternoon, everyone. I'm sure that we've been richly stimulated by all the lectures we've heard today, and it has given us a lot of food for thought. So on behalf of all the members of the ARD executive, I want to appreciate everyone for joining us to make this scientific conference a resounding success. We especially want to thank the chief host, Dr. Alimi, the chairman of the occasion, Professor Yuson, and all our speakers who gave us stimulating lectures. We appreciate you all. We also look forward to meeting all of us again at the end of this year, when we'll be having our annual general meeting, where we'll also have interesting speakers to speak on topical issues of the day. So once again, thank you everyone for coming and joining us, and we hope that you've been richly stimulated. Thank you.
Thank you very much. That was the Vice President of the ARD NOHIL. Would want to close this scientific conference by calling on our immediate past president in the person of Dr. Noah Oyedeokun to please give us a closing prayer.
Thank you. We're praying. Alhamdulillah, Rabbil Alamin. Ar-Rahman Ar-Rahim. Maliki Yawmiddin. Iyyaka na'budu wa iyyaka nasta'in. Ihdina as-sirata al-mustaqim. Sirata alladhina an'amta 'alayhim ghayril maghdubi 'alayhim waladdallin. Amin.
Thank you very much. We now bring to a close this program. We appreciate everyone for being a part of this historic event. We hope that we all have learned something and we continue to interact with these discussions. Thank you very much and stay blessed. The OGM proper will commence at 2 p.m. Thank you very much. All members are enjoined to log in, and the meeting starts once quorum is formed. Please kindly use your identifiable names. Thank you.
Sorry.